Now, the one area that I've really looked at recently, and it's been a big push for me, is substance use and OCD.
Yes.
Our work with Riley's Wish and Margaret Sisson, and the death of her son, unfortunately, from an overdose, who had OCD. And I now really think about substance use as the fourth safety-seeking behavior. I always talked about three, as in avoidance, reassurance, and distraction, but now really seeing that fourth one is substance use, that immediately eliminating as much as I can those intrusive thoughts by zoning myself out with some extra chemicals that are going on, and how dangerous that is, and really the proliferation of a few things, and this is just a general warning, maybe outside of OCD for a second, but you'd be amazed, and maybe you working with kids too, this I think is really, really important. Do you know how many people get hooked on opioids from dental experiences?
No.
It's massive. The number of people that we see who say, my first experience with opioids was after braces or a tooth extraction or something like that, and I got codeine or a couple of things just for a few days. But the amount that kids get hooked on that and become adult addicts, I'm shocked at what we see. So it's just something that I think any of us who might treat children and know that maybe there's a dental procedure coming up, just have a conversation with parents about, hey, take a look at what kind of painkillers are going on. If a doctor's even prescribing a 30-day supply, you probably only need 3 days for most dental procedures, only need about 3 days of something. And so just get a couple of days or maybe a week at most. But watch out for those big supplies that come in. So that's just my little soapboxy thing on that.
No,
but
it's good.
I think it's important. So many people can develop a substance use disorder when they get anxiety as adolescents, and we even, sadly, in I think sometimes in our medical community, there's a lot of doctors who want to prescribe benzodiazepines because we have a belief that says fear is bad and you shouldn't experience any fear. So take this benzodiazepine as a way to knock that fear out, and then you'll feel great. And then we also get the number of people who come in hooked on benzodiazepines. We've had people up to 20 milligrams of Xanax a day at our residential center. I know, it's
I had a guy come from on 12.
Wow.
He was working his way down from 12. But yeah, that's a big number.
Or also sleep medication too,
Sure.
when people are really, really anxious as well. 200 milligrams of Ambien is our record so far.
That's pretty good.
So there's a lot of substance abuse in the anxiety community, and I'll say this from my own training in a PhD program, that was never really looked at as substance use. I took a substance abuse course and it was an elective. I didn't even have to. So I'm on a bit of a soapbox lately with all graduate schools that substance abuse course ought to be mandatory in graduate school instead of just focusing on the mental health pieces and saying, well, the addictions get treated differently. I think we've got to fix that, and we've got to really take a look that addiction is just as important to look at as mental health issues.
I think in a lot of master's programs it is.
That's great. But I don't think it's in a lot of doctoral programs.
I don't think it is either. That's the reason after I decided to end my graduate career after my master's, I had to take 4 additional courses to meet the KCREP licensing for the LCPC. So I had to take some extra ones, and one of them was a substance abuse course because we weren't required. I didn't even know if there was one, but it wasn't part of the curriculum.
So I'm really hoping that we get more people involved in looking at the co-occurrence of substance use and anxiety disorders. It's one thing we treat at our residential treatment center, the Foglia Family Foundation Residential Treatment Center, part of AMITA Health, where we will take people who have co-occurring anxiety and substance use versus the other residentials will not. They will want you to work on one and then the other, and we'll do it as a co-occurring piece, which I think is so important because to me it doesn't make a lot of sense to say, let's take away your main coping strategy but not treat you for the thing that's causing you to need it for at least 30 to 90 days, and then you can get treatment for it. So
seems legit.
I like the fact that we're trying to do both of them together. So that is out there now, that we're really trying to focus more on this co-occurring piece.